Good morning. My name is Janet and I'm the faculty leading this discussion today. Our goal is to conduct a case study analysis, and I'm working with BScN second year students, and my overall goal is to link clinical practice to theory and to emphasize gerontological principles in our care as nurses. So when we look at case study analysis, we say, why do we do case study analysis? One of the things that we celebrate through this process is that it actively involves students. It builds on students' current knowledge, builds on their previous knowledge, it creates new relevant knowledge, it stimulates interest and reflection in care, and it also can be used in the classroom, hybrid, and in online environments. So when a student takes the role in a case learning activity, they may take the role of the scribe, tutor, chair, or group member. And each has a role and each has a responsibility. So we would review that as a group prior to beginning this activity. Case study analysis also needs to fit within the purpose of the course and within the curriculum. It builds critical thinking skills which are essential for nurses to be successful in practice. The educator, I will take the role of a facilitator. I will make sure that if there's a rubric attached to this activity, that the students would have that disclosed to them prior. So when we look at a case study, we want to thank the student for bringing the information forward, and I have set objectives for this activity. So I want the students to demonstrate that they can take case study data from an acute care illness and a client with complex comorbidities and collect the data, map it into a concept map, begin to formulate and prioritize nursing diagnoses, nursing sensitive outcomes, and nursing interventions with a clear rationale. In order to participate in this activity, the students would have in preparation a case study analysis tool, and this is what we use in my present practice to guide the students' thinking and decision making. So on page 1, which is on the left side of your screen, there's anatomical bodies, and the systems assessment is through the center of the tool. The second phase of the tool is to have the students build a concept map, create nursing diagnosis, nursing sensitive outcomes, and interventions. So the resources the students need are pathophysiology textbook, physical assessment textbook, nursing diagnosis handbook, access to credible websites, patient safety infection control knowledge, and of course overall gerontological nursing textbooks, and our goal is to apply those principles through the case study. So one of the students would read out the case study and give us an introduction to the client, and my responsibility is to begin to facilitate the activity. So the students will complete page 1 of the tool and start as a group to not only identify their role but also to map out the information that they know. So I would expect to see information around sepsis, pneumonia, the dehydration, her confusion, potential delirium, her skin condition, and her psychosocial information, as well as her past history. The second part of the activity, which would be another 5 to 7 minutes, would be to have the students begin to build concept maps around each clinical problem, and to identify strengths, but also to list information that they don't know about each system. So for example, we should start at this point, I should start to see the concept maps growing with more detail and with more information. The students then take a black line or a dark colored circle and begin to cluster the pieces of information together that they can then use to build a nursing diagnosis. So we would then, as a group, I would facilitate the discussion, and we would essentially start with respiratory and sepsis, and why do older adults atypically present with this type of an infection. So we could look at the criteria for sepsis, and why, though 38.3 is the criteria, why presenting with a temperature of 37.5 meets the criteria because of the person's an older adult. We also have missing information. We know that we don't know the white count, yet we know she's in pulmonary distress, and we also have missing information around her renal system. So we can move from pathophysiology, we can move to signs and symptoms and clinical presentation, and then we can create a list of information of things that we need to ask the nurse practitioner or the physician leading her care. We also can start to identify what a vital sign monitoring pattern would be. What about her oral and IV hydration? And we have more questions than answers about her own oxygen use. And overall, these are interfering with her need for rest and sleep as one of her basic needs. Similar pattern would follow around the discussion around cardiovascular. Her cardiovascular collapse with a low blood pressure is not only a symptom of sepsis, but also can be a complication of delirium. So we know she's trying to pull her IV rate out. We have questions as to whether she's tolerating her oral antibiotic or whether that should be given IV. We need more information. Again, applying older adult principles, we want to have a discussion around mortality and sepsis, and that those mortality rates are high. And again, we want to create a care plan that reflects vital sign monitoring, blood pressure parameters, and urinary output. Similar conversation and facilitate discussion around the fact that confusion is not a normal part of aging, and that acute confusion is delirium or potential delirium, and we need to put into place a screening tool. We need to put into place take active steps in order to reduce the risk of mortality related to delirium. We want to have a discussion around the prevalence of delirium, how to identify delirium, and how it's different than depression or dementia. And we would refer and have a discussion around credible websites and credible information. And again, we have questions around what is the client's normal status in her home, her normal cognitive status in residential care. So again, the discussion around musculoskeletal care and her mobility, we can bring in the discussion around ethics and the use of restraints. So what we know is the client is potentially mobile. She's trying to get up, agitated. Was there a mobility assessment done? What is her falls risk? We want to know whether or not there's assessment tools in place and a falls risk score, whether it's been completed. Environmentally is part of keeping her safe on delirium watch. We want to look at the ethics of restraining a client in a geriatric chair. And again, we need more information from her care workers and her daughter. Similarly, around the gastrointestinal system, although she has urgency, we're not sure, diarrhea with urgency, we're not sure that she's not constipated. We don't have a bowel assessment. We know her urinary catheter is in place. We know that ideally we would like her to be on a toileting routine and have a toileting journal kept versus having an indwelling Foley. So we have some information and we need more information. We don't know we don't have a bowel assessment. We don't know what her perianal skin condition is. We don't know if there's any skin protectants being used. And again, underlying this is pain. Is it constipation pain? We don't know what's causing her confusion. And are these issues additional sources of sepsis for this client? Of great interest to me is medication use in older adults. So understanding the links between medication and older adults is crucial. Polypharmacy in this population is rampant. The nurses need to understand that each drug comes with complications and potential contraindications. So we want the students to identify the class of drug, what is a therapeutic range for an older adult, what is the use of risk with an older adult, and what are side effects. For example, Lasix is a loop diuretic, and yet we know that it hinders the effects of an oral anti-diabetic medication. So I want to generate a conversation with the students that there are complications and risks to each medication. And for example, Ativan use. Is this a new drug for the client, or has she used this before? It's excreted in the urine, and yet the client has concentrated urine. So this medication discussion, I find from my present work, often generates very interesting conversations and lots of learning for the students. And again, overall, we want to emphasize the principles of diabetes care and the Canadian Diabetic Association guidelines that came out in May of 2013, and that there's an online app that the students can use. I want to generate a discussion so that the students understand why, and will begin to question as to why diabetes is placed in her past history even though she's currently on medications. We have questions around her glucose monitoring, her current weight, and again, we need more information from her daughter and the staff at residential care. Almost as important as sepsis, and I would have had this at the beginning of the discussion with the students, is around her psychosocial care. Where is this client's family? Well, we know she's asking for her daughter, and we know she lives within a residential care community. And so those are really important pieces of information to respect when caring for an older adult. So we want to ask what is happening. We want to know what it would take for this client to safely return to her known environment, and what family meetings and team referrals need to occur. And finally, we want to have a discussion around pressure ulcer prevention, assessment, management, and treatment. What we do know is that she was admitted with a stage 1 pressure ulcer on her coccyx, and the student identified as stage 2. We're not sure of the exact location, the size of those ulcers, and so we want to have a discussion around the National Pressure Ulcer Advisory Panel. What is the correct way to stage an ulcer and to not backstage ulcers? And again, what is the role of a Braden scale or a credible tool to identify for further risk? So from this activity, the nurses will have developed a concept map, and they then need to move forward to create nursing diagnosis, nursing sensitive outcomes, and interventions. For example, I would expect to see from the groups examples such as impaired gas exchange related to her cognitive status and or her decreased oxygen saturation, which we know is related to the pneumonia, and that the client will demonstrate improved respiratory status or gas exchange with the following parameters. Her respiratory rate will be 10 to 12. Similarly, acute confusion related to delirium or sepsis, the client will demonstrate a restoration of cognitive status to previous status. So just in closing, that's an example of how I would walk the students through a case study, and again remind them that clinical practice is linked to theory in a positive, proactive way, and that we will do further case studies, and I encourage the students to bring forward interesting case studies so that we can learn from them as a group. So as wrap up, I would want to have a discussion just around why we do case studies, and that case studies are like a fan, and that you can start at the hub and build out new information. We want to emphasize that it's important to be able to work in groups as students, because you will work in a group as a nurse on the unit or in the area that you practice, and to remind nursing students their nursing diagnosis handbook, for example, helps them understand the nursing role. To thank the students, and then we would probably take a quick coffee break and move on to the next activity in the session for this week. Thank you for your time, and I look forward to your feedback and questions.